It's great to be here. It's great to have fun. It's great to be present, and it's great that Stockholm is showing off with sunshine. For those of you who came in over the weekend, you really missed, what Stockholm could be. But today we're showing off really well. I'm a pharmacist by training. I've spent almost 30 years in big pharma, traveling around the world before joining EY in actually 4 years ago in spring of 2022. I work in business development across health and life sciences in good company with 55,000 other individuals also serving the health and life sciences sectors. Overall, EY has some 460,000 employees or so. It's an immense amount of people that you can't even imagine how many those are. But I'm very pleased to have been asked and given the opportunity to interact with you this morning on brain health. Incredibly interesting topic, and I'm very much looking forward to the discussion. We'll spend a little over an hour here, first in a keynote session, and then we'll have a panel with 3 short talks, followed by a discussion. And of course, we would like you to be very interactive. So, as we go through the morning, think about your questions, be prepared because we'll have plenty of time for interactions in our panel. And as I said, little over an hour for the first session. So without further ado, I think we're immensely proud, Pernilla, to have Professor Norrving with us here today. I think few people have done more within brain health and neurology to really put it on the global map of prioritization, also leading to a Lifetime Achievement Award that was given some time back from the World Federation of Neurology. And today, we're going to hear you, Professor Norrving, from Lund University, on the stroke revolution. So welcome on stage.
So, thank you so much, Thomas. Thank you so much, Pernilla, for inviting me. And what an honor to be here at this meeting. And what a pleasure it is, really. So I will speak to you about stroke revolution. As you can see, I'm senior professor in neurology at Lund University, and I was also one of the founders of the World Stroke Organization and the president for a period, and the UN and WHO representative for many years, really. So I'm past retirement age, but I still work 100%, and even more of that will research and different commitments. My disclosures and what images do we have of stroke? Well, here is one famous person who had a very severe stroke just at the age of 59. And you know his stories, that he was able to struggle and to continue to write Japanese poems. And you can see one very moving here, that I'm carried in my shadow like a violin in its cage. The only thing I want to say glimmers without reach, like the silver at the pawnbroker. He had an extremely severe aphasia. He was hemiplegic, and he could say almost nothing, just a few words, and he was desperate to see. So it's one example of a very severe stroke and the consequences. But when we look at the phases of stroke, it can express itself in so many ways. It can be of different severity, but every case here is a life story, really. So if we're going back to middle of the 19th century, the British neurologist to say treating stroke, well, what can you do? It's a hole in the brain. It's nothing you can do, really. And when I came into this field, and I started at the stroke unit 52 years ago, stroke has the lowest priority at the emergency department. We have no acute therapy. Patients who could have no rehabilitation, by definitions younger than 65 years of age, they were sent out to different departments, different wards at the hospital, because nothing could be done, really. Bed rest for 1 week. We didn't have a CT scan. Patients with TIAs were sent home, and we were convinced that there will never be an acute therapy, because in a few minutes the brain will get damaged and you can do nothing. So before we are looking at the revolution in the treatments, a few slides on the revolution of what we know about the size of the stroke problem and the effects. So if I take the next slide here, it doesn't work, I cannot advance it. Here it is, yes. Looking back 23 years ago, what was the knowledge at that time? What you see here are a few dots in different parts of the world, and we thought it was quite similar in different parts of the world, the little information that we had, but we recognized that this was very little of information actually. If we move up 17 years ago, then we saw the first trends that seems to be some improvement in high-income countries, but it was first time when we saw that in the lower middle-income countries is going in the opposite direction. It's not going well there, but this is quite recent, and not until 12 years ago did we have this global picture on what is happening with stroke in the world, and this was shocking to see that there are huge differences. The huge burden is in lower middle income countries. It was much bigger differences than we had ever thought. It was a much larger disease than we have ever thought. It was a shock. It was the first time that we really saw that this is much more serious. This is a catastrophe. This is very, very important. But this knowledge is not very old, really. If we just make a comparison, we have 7 million stroke per death. This equals to 25,000 airplane crashes per year. This is something which is ongoing, just to imagine the enormous burden of stroke. So if we look at some other data here from the World Stroke Organization, 12 million new strokes per year, 7 millionth death, almost 100 million people live with a stroke in the world. 1 in 4 people, 1 in 4 of us, will have a stroke during the lifetime, and the large burden of stroke is in the lower middle income countries. So another aspect is here that more than half of all strokes in the world are happening in people younger than 70 years. Meaning that stroke is a major cause of disability in the working age groups. We can see the situation in a lower middle income country. If someone in the family has a stroke, it can be catastrophe for the entire family. It can put into poverty and have very traumatic effects. So stroke has many faces. Stroke is really a severe disease, and we recognize the burden, but of course the burden is just a start. The important thing is, what can we do? Can we treat? Can we prevent it? And the answer today is yes, we can. Part of this is now the stroke revolution that happened. As I said, we were convinced 50 years ago there will never be acute therapy. And then about 30, 40 years, it started to change. Yes, there is a possibility. And since 20 years, we had about intravenous thrombolytic therapy. And since about 10 years, we have an even more effective therapy with thrombectomy, really. So this is the enormous revolution that we had for the first time to be able to treat acute stroke, to take away the clot in the brain. And here you also need a collaboration with patients and with carers and with the hospital system. We cannot do the therapy if the patient does not come into hospital in time. And we know that in 9 patients out of 10, it's not the patient himself who calls 112 and says, I think I have a stroke. Is someone around you? And it means that everybody in the community needs to have the knowledge of stroke and needs to take up the telephone and needs to do it. It's not the patient themselves. So this is one of the important messages, to recognize the acute symptoms of stroke. The first therapy to come around was intravenous thrombolytic therapy. And this is actually low technology. It needs knowledge how to do. It needs a patient coming in time. It needs a CT scan to exclude a hemorrhage, and it needs a drug to be injected. But that is all. It's not high technology. It's a relatively easy therapy to give, really. And the next dramatic step, and I think I will click up this, worth thrombectomy, which was firmly established 10 years ago. And with thrombectomy, you put up a device, you take away the clot mechanically. And this was an enormous revolution, that the first time in history we can treat the most severe patients, those who suffered lifelong, like Thomas Tranströmer. For the first time, we can take away it, and we have a dramatical improvement in very many of these patients. It's a remarkable achievement, really, which is almost impossible to understand how big step this was. And here you can see to the left, you see the blocked artery, you see if blood is coming through, you see on the right side now is reperfusion and the clot is taken out, really. So this now needs transportation of patients between hospitals who can do this procedure, 8 hospitals in Sweden for the moment, and it also means that 25% of all Swedish stroke patients are transferred now to another hospital for possible thrombectomy. It's one of the most effective therapies that we have in medicine overall. And in Europe, I was responsible for the action plan for stroke in Europe. This was done in close collaboration with the patients' organization, and this is now in implementation phase. It's the largest stroke projects ever undertaken in Europe. Implementation part of this is to collect the data on how is it in the different European countries. Here you see stroke unit care, Sweden, Scandinavian countries, green. Here we see intravenous thrombolytic therapy, and here we see a very rapid increase and a rapid uptake in different countries. And on this slide, we see thrombectomy rates, which is also coming up very, very quickly. So what we do in Europe is to have this annual collected data. We show the progress. We see enormous rapid progress in some parts of the world. The stroke action plan is connected with the implementation science. We have national coordinators. We see that the reach is out. That is not only a paper on the shelf, not only a declaration, but also an implementation. And what is doing here in Europe is a prototype that can be used in other parts of the world as well, to have the data to monitor the progress, to identify the barriers. So what we see on the revolution in a global scale is, yes, we have got effective therapy, remarkably effective therapy, but the large majority of patients with stroke in the world, they never see this therapy. They don't even come close to it, really. So the implementation here is a major problem. A few words about intracerebral hemorrhage. The breakthrough was in ischemic stroke with a blood clot. We do not have the similar very effective therapy now with intracerebral hemorrhage. This is one of the important areas now on research to get better therapies here. A few words also about stroke prevention, because this is of course very, very important. And here we see another revolution. What do we know about the effect, the risk factors for stroke? Well, we know a lot. 80 to 90% of stroke can be explained by modifiable risk factors. 10 risk factors can explain 80%. There is extreme huge preventive potential for stroke, about double as much as a potential for cancer and for dementia. We can potentially do very much here. And the one risk factor that is definitively number one in all parts of the world is hypertension. And I will just focus now on hypertension in a few slides. This is from a WHO Global Hypertension Report. And what we can see in the breakdown is proportion of patients or persons with undiagnosed hypertension, with treated hypertension, and the very small part with detected and under control. And what you see in the bottom line is that only 1 in 5 have the disease under control. So this is the major risk factors, is the most important one, but we have a major problem to reach out with the detection and therapy in the hypertension. And this also accounts for Sweden. We can estimate that effective therapy would save enormous amounts of strokes, myocardial infarctions, and it's absolutely essential to have prevention much stronger than we have today. Do we see that? Yes, we see that. One of the remarkable revolutions we see also is the development of stroke in Sweden. Over 20 years, stroke in Sweden has been cut in half, and this is absolutely remarkable. Its mortality, its number of new cases, every metrics is cut in half. And looking in another way, this was a survival kit for the health system. Without risk reduction, stroke units would have flooded. There will never have been enough of beds to take care of these patients. It demonstrates the potential, and it demonstrates what can be done in other parts of the world. We see improvements, but Sweden is one of the countries that have the strongest data in terms of prevention. We have much better possibilities today also to prevent new strokes by this combination of different secondary prevention actions, and I don't read the details here. If we look again out in the world, what's the situation there? Again, that we have made a revolution in the potential, the possibility to prevent, but is far too weak in the implementation. And this is one of the obligations we have, to reach out also with prevention. So I'm co-chair of the Global Stroke Action Coalition. This is action where industry, where the stroke societies and patients' organizations go together with one common message now to WHO, to the UN, to decision makers: put the focus on stroke, invest in stroke, it will pay back, it is extremely cost effective. So this is ongoing. If things are going well, there will be a stroke resolution for the first time at the WHO World Health Assembly in May this year. We're crossing the fingers for that. That will be a major achievement. And my final slide, the stroke revolution. Stroke has been in the shadow far too long. Major recent advances in acute stroke therapies, enormous potential preventions. Interventions are extremely cost effective, and the major problem today, majority of stroke patients in the world do not receive these standards of care. So we need to act urgently. We have this possibility, and we are working together on this. So with that, I thank you.
So Professor Norrving, thank you very much for a wonderful keynote. Maybe just a reflection as I was hearing you and reading your slides. So I saw revolution, I saw resolution. When I looked at some of the maps, I would have said maybe evolution is missing.
Yes.
What's driving that?
Many factors, but partly is related to the other SDGs with the economic problems, with the status of the health system. Very much is also up to decision makers. And in particular, when they come to the strengths of primary prevention, which is crucial, there is far too little done. There are very much of the therapies that can be implemented at lower reasonable cost, which is not being done. So it's very much, it needs the power of decision makers. It needs a collaboration with the patient groups to also support this. This is very important. But we see that we can put much more into this. And of course, we see the tragedy today that money is spent on war. We see the amounts of, and we see that as a threat towards the health system and the economies, of course, that money is put in the wrong way.
It was quite obvious when you saw the colors that there was a revolution in, Europe, northern, and then, a bit in the middle, and then even off to the left-hand side, a country like UK was, marked with a different color, indicating, big differences in between them. So there are breakthrough therapies that have come. These are, I think, part of why you chose the word revolution in your slides. But what does it take to convert, the medical breakthroughs into long-term sustainable policies and decision-making?
I think here we need to work with implementation science, and this is a learning curve that we had the first European consensus of stroke 1995. We had the second 2006, and what we learned now for the last one is that it's not enough just to have a declaration. We need to have an implementation plan. We need to come out and reach out in the countries. We need national coordinators. Each country is autonomous when it comes to decisions in healthcare. We need to reach out there, identify the barriers, see the good examples, and really force it through. So I think we have the way to go forward, but it doesn't come overnight.
And are we doing that?
Yes, we are.
Pushing forward?
Yes, we are pushing forward. I would say, and I see with pleasure that the race of stroke, the recognition of stroke, the awareness of stroke that was not seen 30 years ago. I started with advocacy in the 1990s and approaching WHO, stroke was invisible. Maybe it was under mental health and substance abuse, but no, we didn't find it.
Possibly.
And then a lot of things has happened after that, really. So it takes a long way. Yeah.
Wonderful. Let's see if there are any questions from the audience. Yes, I think there's one in the back. Let's see if there's a microphone or whether we need you to... Yes, if you come a little bit closer,
Yes,
that's
come
much better.
closer.
Then we
Yeah.
can also...
So thank you very much for the amazing presentation.
I come closer to you.
I was just going to repeat the question, but that's fine.
Yeah.
Okay.
But I need to hear it first.
Yes.
My question is, what makes it so successful in Sweden in terms of prevention and because the figures are incredibly spectacular.
What makes
Yeah.
Sweden successful
Sweden
in our
successful?
prevention and measures?
I would say that Sweden has a unique combination of, we have a strong driving force in the National Board of Health and Welfare. We had the National Stroke Guidelines. Sweden established the first national stroke register in the world. So very early in 1994, we got national data. And that has been very, very driving for this combination also, and a strong implementation. So what we are good at in Sweden is prevention. We saw this miracle of stroke cut in half. We see good acute therapies. Everything is not good in Sweden. What is lacking is life after stroke, is a follow-up after stroke, is to taking care of rehabilitation long term. This is the Achilles heel, I would say, of Swedish stroke care. But the acute care, it works well. Prevention, relatively well, but it could be much stronger.
And would you say that our stroke care is sort of paving the foundation for a broader focus on brain health as opposed just to stroke as one of the diseases?
Absolutely. And if we see at the different brain diseases, stroke accounts for 40%, then comes dementia and other diseases, but stroke is one of the strongest here, and this is clinical stroke, and we do not recognize here in this calculation the silent vascular damage that is occurring in the brain, which affects cognition, which leads to dementia, often with other diseases with risk factors or so. This is another very big part that also comes into the concept of brain health.
Great. Is there another question? Yes.
Yes, I have a question. No microphone? No?
Oh, there is a microphone coming.
Okay, great.
Give us a second.
Hi, my name is Hannah Brother, and
It's on.
Okay, great. My name is Hannah Brother, and I'm the editor-in-chief of the magazine Neurology in Sweden. Thank you for your presentation. Very interesting. And I have a question about Sweden. You said that we are not as good as we could be in prevention, and the treatment is fairly cheap. Why? And people go to see the doctors. So why aren't we better in prevention? And why don't people take the preventive medications that we really have?
Yes. I think a problem we have in Sweden, major problem has been the detection of hypertension. Blood pressure control, the easy availability of blood pressure control, which is now changing. We have changes in lifestyle, but in my opinion, it could have been much stronger enforced by the politicians and by the government, that doing changes in food, in salt consumption, in sugar consumption, also that could have been much stronger than it has been. And then we see, of course, that very much is going in the right ways. Not a few factors is if we have Ingvar Skog's book about 70 is a new 50, that is multi-dimensional. So much is happening that is a better life situation that contributes to this. But still, I think we are missing things in prevention, which is not enough. It's extremely difficult to reach out with physical activity. We have the obesity problem ahead of us, which will not escape us, of course, and we need actions here really. But in general, I think there should be a much stronger voice on prevention, and also to look at it from politicians, as I said, that this is a survival kit. We need to do reductions. We need to go down for the health systems to survive in the longer term. Otherwise, you cannot have the capacity for this if we look in decades ahead.
Wonderful. We are almost out of time. We have a time for a very short question. There's one in the first row here. If you could get the mic going. Peter, thank you.
You haven't talked about rehabilitation, about the physical training, because I look at the woman in her name is Sofia, and she was a gymnast, and she exercised with table tennis to just exercise and have rehabilitation. Could you say something about that?
Yes. Yes, and no, I didn't mention it because I couldn't mention every aspect of this, but of course this part of what is happening after the stroke, what is with the follow-up, with the rehabilitation, and with the training. And what we see in Sweden is that it's extremely heterogeneous. If we look at different regions, what type of rehabilitation is given, to what extent, how much, in which type of organization. Some regions have home rehabilitations, others do not have, and this is something that we are now looking into in detail and see how much is given, what quantities, to which patients, what are the inequalities, and we see directly from what little we've seen that elderly patients are disqualified. They are not so much given on rehabilitation. A minority of patients are given very much of rehabilitation in a long time. So it seems that we need to have this all redefined, and I think the concept that we try to establish is that in the acute phase now, we have organized stroke care. We have organized stroke units. We have everything is in place. It goes rapidly. We need to transform that also in the follow-up phase with structured follow-up, with rehabilitation, with lifestyle, with prevention, with all the different things that needs to be followed up after stroke, and set up such a system. We have that recommendation in the national Swedish guidelines. It has priority 2. It should be a structured follow-up, but you don't change this overnight. Rehabilitation is extremely important, not only by professional staff, but also what you can train yourself and to help to do this.
Thank you very much, and you'll come back for the discussion as well. We'll
Thank
give you
you.
thank you.
Thank you.
Thank you. So, as I said in the introduction, we'll now follow on with 3 speakers. Before we go into a panel, it's my pleasure to welcome Joakim Ramsberg, Research Director from the Swedish Brain Foundation. Welcome. Thank you. Good to see you.
Yes. So I'm from the Swedish Brain Foundation, and we have the enormous privilege of working with research on the whole brain and everything that comes with it. And that's fantastic. And today we're going to talk about the societal burden of brain diagnosis. And this is an enormous topic that I will try to cover in quite a short time. So as you will see, I will try to get about 30 billion Swedish kronas worth per minute now. So I'm going to try to make it count these minutes. And the starting point for our work is, of course, that we live our whole lives in our brains. everything we feel, every emotion, every experience, everything that humans create is inside the brain. And that is, of course, why different disorders and diagnoses in the brain are hitting so hard on individuals and on society. And this is just a small number of the different diagnoses that can affect the brain. And I'm sorry, they're in Swedish now, but I'm sure you're all aware of the different diagnoses that can affect us humans, and they count in the hundreds, obviously, and you recognize many of these. And in fact, about 40% of the Swedish population has one or more diagnoses in the brain today, are living with that. And it's about 4 million people, obviously. And also 4 of the 10 largest causes of disease burden sits within the brain. So it affects a huge number of people, and they are affected quite severely. And if we put together how functioning is affected and how the lifespan is affected, you can get a measure like the DALY, the Disability Life Years, which is how WHO measures disease burden. And counting all the different diagnoses in the brain together, about 26% of the total disease burden sits in brain diagnosis. And to put this into some kind of perspective, all cancers taken together are about 17% of DALYs. And so it's an enormous burden, obviously. And it's not only that functioning is affected, but a large proportion of deaths are also caused by diseases of the brain. So 22% of all deaths can be attributed to brain disorders. And these are, of course, staggering numbers, and a huge number of people are affected. And it is both mortality and morbidity and functioning and quality of life that is affected. And it's an enormous toll on individuals and on their families, on caregivers and so on. But it's also a very large issue for society in terms of there are different costs associated with caring for all of these people. And there are also lots and lots of costs associated with lost productivity from all of these diseases. And putting it all together, the total cost, if you sum up both direct costs in healthcare and social care and so on, together with indirect costs such as productivity losses, it's about 300 billion Swedish kronor per year. And it's, of course, associated with some difficulties to make this kind of calculations, but this is, I would say, a quite conservative estimate, actually, of the total costs. And if we look at the different components, this apparatus makes it difficult to look at the different components. But here we go. And the total, I mean, the sheer number of people and how hard they are affected makes the consequences very, very large. And taken together with the lack of treatments for a lot of these disorders, have very large consequences for healthcare, which is about almost 30% of these 300 billion. Direct medical costs are 17%. That's the cost on the healthcare system. And a large portion of the 29%, which are direct non-medical costs, as they're called, are for taking care of people, especially with Alzheimer's disease and other cognitive diseases, especially in older age. But so actually quite a lot of psychiatric conditions in there as well that are taken care of by the social care services. And the largest proportion is on lost productivity. That is people that aren't able to work. And in that number, we count both people who are on sickness absence from work, but also people who die prematurely and can't work for that reason, of course. But what is not counted, but which is a very large sum, is actually what is called presenteeism, people that are at their jobs but are not functioning as well as they should and could on their healthy days. And one typical example of that is migraine and other headache disorders or stress-related disorders of the brain, where people go to work but aren't producing as much as they should. And this is a huge loss for society. And looking at these different costs, an interesting pattern emerges. So that we see there are different diseases and disorders and diagnoses that are causing the direct costs that are causing most of the indirect productivity losses. And Alzheimer's and other dementia disorders are causing the highest direct costs. And we also see that depression, substance abuse disorders, anxiety, OCD, and sleep disorders also, they're causing quite high direct costs. But if we then look at the indirect cost, headache disorders is a very large sum, but also, again, depression. But then we have diseases like schizophrenia and bipolar disorders, which are characterized by a lot of people not being in the workforce at all for a very large part of their lives, which of course is a huge loss to society. And if we think about the consequences for individuals and also for society and for families and everyone around these people, it's quite obvious that there's an enormous need for better treatments of these disorders. And in fact, for the large majority of these disorders, there aren't any well-functioning treatments that can affect the course of the disease and save people's lives and so on. There, with some exceptions, obviously, like stroke has made huge strides, but a lot of neurological and psychiatric disorders don't have that. And in fact, there are also a lack of effective diagnostic methods that can be used to find these patients. And we at the Brain Foundation and also a lot of other actors, of course, think that research into this should be in parity with the burden on individuals and families and societies, which it isn't today. So brain research is very, very underfunded in relation to the impact on people and on societies. Yeah, and that was my 300 billions worth of talk. Thank you.
Thank you very much for that introduction. Don't leave yet. I have a question for
you.
You.
Have questions?
There might be more questions.
Oh, you think?
I'm sure there are. So if policymakers and politicians would have been sitting here today to see the data that you just presented, what's the one single thing that you would want them to do after having heard that presentation?
Well, coming where I come from, I think they need to increase funding and capabilities for research into brain disorders, because there are, of course, lots of things we can implement already today, and they should implement. Everyone who needs acute care for stroke should get that, obviously. And we should implement what is known in psychiatry and have evidence-based care. But we need a lot more fundamental breakthroughs and being able to treat these disorders more fundamentally. And that's why we need more research.
Okay, so if you were then given, let's say, the 300 billion equivalent of funding, would you say that it should be invested in prevention, early diagnosis, or translating research into clinical care?
Well, the boring answer is that you should do all of those things, of course, and the fields are it's moving ahead at different pace in different areas, and you're closer to breakthroughs in some areas than others. And when you have But the one problem is that there is a lack of basic understanding of how the brain actually works, even a healthy brain. And that is what stops, that's what prevents breakthroughs in some areas. We need to keep focusing also on basic and fundamental research. But then in other fields, you're at the translational phase, we need to turn these findings into actual treatments and diagnostic methods and so on. And in other cases, we already have treatments and so on that should be put to use in actual patients. And of course, there are lots of things we can do to take care of our brains. And we also, as a society, we don't take enough, we don't make room for everyone's brains. Not everyone has the same capabilities, and it's like society is constructed only one type of brain. There is only room for a certain type of people. And that won't go away even with more research. That's more about values and how we look at people and so on. So there are things we need to do on all kinds of levels.
And inclusion of neurodiverse individuals
Yeah.
also in work life and school and everything.
Obviously, yeah, sometimes for example, I mean, a lot of things that are going on in the brain, they're distributed across the population at various levels. But if you look at some, the workforce, for example, sometimes it feels like everyone has to be above average in, say, I don't know, general intelligence to get a job. But by definition, half of the people won't be, and so on. And there are all kinds of aspects of our personalities and brains that are like that. And that's something we as a society should think a little bit harder about, I think.
I think everybody needs to be in the top quartile and extremely experienced, even if they're only 25.
Yes, society it feels like society. We only have society for those people, but actually we don't. Everyone has the same right to be in society.
Great. Thank you very much.
Thank you. Good.
Now I have the pleasure of welcoming Alex Guedes da Silva, who is the president of Multiple Sclerosis Society in Portugal. There is an interesting initiative that we will hear more about, a way of structuring things that could be a learning experience for us as well in Sweden.
Okay.
There you go. There's the chair.
Yeah, I'm good. Hello, everybody. Good morning.
Good morning.
Okay. They give me a very difficult task. And the difficult task is why we Portuguese will teach you something. It's tough. It's tough. Okay, let's see what brings us here. I was very much involved in policy making and in Brussels, trying to help the European Brain Council and DEFNA in lobbying for what at the moment was a dispute between children cancer and neurological diseases. And what happens at that time was the decision to implement a pillar of research and a lot of money direct to one area of health. And we were not able at that time to make the brain sexy enough to be chosen as the focus for European research and to become a pillar in or to become a mission in Europe. I think I spoke with Guedes at the time. He was a former colleague of mine at university, and he told me, Alex, there's no point of advocating now. You have lost 2 years ago, which means that in the next round of negotiations, we need to be prepared. The brain pillar or the brain mission should be prepared now, not by the end of the discussion. That's what we did in Portugal. We realized that we need to organize all the areas that are related with the brain and put all of them under the same umbrella, and with that umbrella try to learn everybody to row synchronously and in the same direction, not opposing each other. And that's what Portugal is doing now. So we joined together neurology, psychiatry, mental health, aging, prevention and rehabilitation under the Brain Health Hub. And this hub is quite interesting because the organization that is conducting all the efforts is the same organization in Portugal that has a similar hub for cancer. So we are learning from cancer how to organize in order to advocate for a brain mission or a brain pillar. And that is what really matters in this discussion. And it's not just an academic or just a medical profession thing. It's a societal union. We have representatives from the patient advocates. I enable architecture only enter there because I'm a patient. I'm a multiple sclerosis patient. But we have also the workforce. So we have the neurologists, we have the psychiatrists, we have the psychologists, we have the physiotherapists, we have everybody on board. And we also have the industry. And the industry, in our point of view, is very important for us because they led, in many cases, the research that can provide solutions. But we have also the academy, because there is a lot to learn about the way the brain works. And we cannot do that without the university. And we have also the healthcare industry with us. All the hospitals, all the clinics, everybody on board. And we try not to skip the fundamental partners, because the decision is political. So we involve the politicians, from the ministry up to the municipality. Everybody was invited to be involved in this movement. And that's why we are in the infancy of the hub. So we have not more than 1 year of work together, but we are learning and learning fast. And especially we are doing a lot of things together, something that was not evident at the beginning, because neurology or brain diseases were always competing with mental health, and mental health was always complaining, we are the losers, we don't have money, we don't have resources. But at the moment, everybody wear the same shirt saying National Hub for Brain, and that's quite important. So that's why we have a kind of a penta-hélice. It's like a propeller of a ship, and we are all together making efforts in order to create a different environment in society for the awareness of the need. The numbers you just put here are not different from the ones in Portugal, so it's exactly the same, and are not different from the ones in Europe. They are basically the same. And if we do nothing, there would be really no response available for the flood of cases that all the healthcare systems would be immersed on. And even for the families, there would be no time to to work, because we need to take care of our relatives. So the potential dimension of the problem is so huge that we need to think now, otherwise we would have no means to resolve it afterwards. So also we need to turn knowledge into impact, and knowledge into impact means two very important things. First of all, we need to realize that living with our body means that we need to take care of our body. We cannot live without walking. We cannot live without having the proper sleep. So we need to tell society that we don't live in a virtual world, our body lives in the real world, and in the real world you have to have time to move yourself, to sleep, and to do all the basic things that your body was built for. And we need to convince our peers in the society that that's an important and a very critical issue. So there we are at the launching of the idea at the medical order, or a professional organization. And as you see, we have the patients on front. And for us, the patients, we are, at the moment in Portugal, we are the spear, the tip of the spear, and we are opening the way. And I think in Sweden, you need to do the same, because all the professions, they cannot speak in the first person voice, but we can explain our colleagues that it's important to act, it's important to invest, it's important to change things. So that's my my contribution to your discussion. We are already 150 organizations, and we hope in 2 years would be around 500 organizations. So it could be unstoppable. Thank you very much.
So just one quick question for you, Alex. It's been a year with this hub, a lot of organizations bringing together. What has been the one key learning from this year that you think, is a send home message to the audience here of, if you do this, something like this can also work here?
Trust. You need to trust each other. And what is interesting is that at the beginning of the idea, everybody was suspicious and said, who will win with this? And at the moment, nobody really cares about who wins. Everybody wants to win together, and that's what is important. We need to win together. Otherwise, nobody wins. Everybody
I like
loses.
that. Thank you very much.
I can see it already.
All right, we can move on to the next. Let me see if we can. Great. Yeah, we can move on then to the next part of the session, the next presentation. It's Nadia Fagrell-Trygg, Senior Research Officer at Forte, and Susanne Frykman, Senior Research Officer in the Swedish Research Council. Go ahead.
Thank you. Do you hear us? Good. We are so happy to be here and to be invited. It will be a very interesting day to listen to all these sessions and presentations. I've already learned a lot. I'm Nadia Fagrell-Trygg, and I work at Forte, Research Council for Health, Working Life and Welfare. And I have with me my colleague from the Swedish Research Council, Susanne Frykman, we are together working in this partnership called Brain Health, the European partnership called Brain Health, that we will introduce you to. Perhaps I should start with this. Yes. Okay. So Brain Health, the European partnership Brain Health, is newly launched. It is under the European Research and Innovation Program that is called Horizon Europe. And together, it brings together 31 countries, 51 partners like us. We are two research funders who then together have contributed approximately 334 million euros, and to which the European Commission has contributed 143 million euros. Yes, and what can I say more? These European partnerships under Horizon Europe, they can be thought of as strategic instruments enabling this kind of collaboration, a transnational long-term collaboration between, on the one hand, then the European Commission and all other countries who want to participate towards a chosen topic and aim. And Brain Health has agreed on this overall aim to speed up the scientific and medical advancement in order to reduce the societal burden. So it was great that you could also hear about the societal burden in the previous talk. To work toward this aim, then, we have also agreed to prioritize. You asked about prioritizations. Should we prioritize prevention, diagnosis, treatment, and so on? We have chosen to prioritize prevention, improving prevention, and also improving early recognition, diagnosis, and monitoring and intervention. And I think the early recognition, here we really try to understand the underlying mechanisms better that we don't already know. And for example, when it comes to monitoring, it will be very important to consider each individual's environmental and biological context. Then when it comes to improving treatment care and support for people living with brain disorders, involving patients will be key. A lot of focus will be, of course, on translating basic research into clinical practice and real impact on health. And lastly then, the last priority is to integrate the social, ethical, and legal dimensions to advance research and innovation for brain health. Yes, and that's very brief. We also have 7 specific objectives. I won't go through them. We have a research agenda if you would like to read more. And there everything is listed. I will hand over to Susanne, who will talk a little bit more about what we will do.
Yes. So how will we then reach these aims that Nadia talked about? So our main activity is these joint funding calls that the research funders like Vetenskapsrådet and Forte, together with research funders in other European countries and also some outside Europe, organize calls for research projects together. And the proposals should then be transnational, consisting of 3 to 6 or 7 partners in different European countries. And we actually just closed the first 2 calls, and we got over 600 proposals. So very popular, I think. And I think this is maybe small contribution to this increased funding for research that Joakim was talking about. I think we need even more, but yeah, we do what we can, I think. But we also have some other activities, and importantly, we have one activity about including and empowering patient and citizens. And this is done by involving patients at all research stages, design, deliver, analyze, and disseminate. And we want to take into account, of course, the needs of the patient and also develop tailored interventions. We have a specific work package, so the work package is sort of one activity in this huge partnership. So we have one work package on empower and engage science and society. We have a patient advisory board. We do consultation with patient representatives. We have workshops, etc. It's just started, so we haven't really done much on this yet, but we will do. We have social innovation and responsible research and innovation strategy. And in the calls then, we have a requirement that you should somehow involve patient and society, citizen. And also to include, preferably include them as partners as well, these patient organizations and civil society organizations. And there is actually a specific budget set aside for these, because as neither Forte or Vetenskapsrådet can unfortunately fund patient organizations, but this is a central way of doing this. So even if you are a Swedish patient organization, you can still participate as a partner. And the PPI approach is also evaluated actually in the review panels, when the panel that decides which projects will be funded. Patient representatives are represented in this review panel as well. Unfortunately, it's too late to sign up for this year, but if you are interested, you can just contact me or Nadia for next year if you would like to participate as a reviewer. You will also get reimbursed for this work. So yes, and then I would just like to pass a question to the panel here on how we better can connect basic research, clinical practice, and patients. And I think this national hub in Portugal could maybe be a good example for that. So which communication channels and platforms can we use, both for valorizing, so take, as you said, knowledge into impact, but also to have active participation from start in the research projects. No? Okay, we just had a thank you slide at the end, but we can skip that. There we are. Okay, thank you.
So maybe just a short question to both of you, because we saw earlier in Professor Norrving's talk, there was, the uneven distribution of advances, so to say, just, across the center of the world that we call Europe. How can an initiative like this bridge, that it becomes more equal?
Yeah, there are, I mean, including also a global approach in this. In this, we are not working so much on that ourselves, but there is a work package on that as well to reach out to the rest of the world and so on. So that is also something that we are going to work on, I will say, since it's just started. But it is included. There is a thought, at least, on.
That's good. And if we look then 5 years ahead, how do we know that this collaboration mattered?
Was there a work package on follow-up and evaluation, perhaps?
So of course, yeah, there is a monitoring work package as well, of course. But I think I personally believe very much on joint international collaborations, because I think that a single researcher in Sweden cannot really do what is needed alone. I really think that you need collaboration, and also intersectoral and involving patient and the society and industry, and I think that's important, but that's just my personal beliefs. But I hope that will at least matter in the end.
And I think that we can reveal that there was a very strong Swedish participation in this first call.
Yes.
So that's
That's good.
Yeah.
At least for Sweden. Yeah. Let's hope we're lucky. But thank you very much to both of you.
Thank you.
So we're now going into a short panel, and I would like to welcome back Professor Norrving on the stage, together with Carina Pettersson, President of the Swedish Stroke Association, and Bengt-Ivar Fransson, Public Affairs Manager from Sanofi. Welcome up. So given that we already heard from two of the panelists here today, maybe Carina, om du vill presentera dig själv, would you like to make an introduction?
Det kan jag göra. Jag är alltså ordförande i Strokeförbundet. Vi är en intresse- och medlemsorganisation, och vi finns över hela Sverige med cirka 60 föreningar. Och varför jag har hamnat i den här organisationen, det är för att jag är anhörig, så jag kan säga där är min bakgrund. Och för 25 år sedan fick min man en stroke. Och jag kan ju se, precis som du säger, att det har hänt fantastiskt mycket. Jag tänker, hade han blivit sjuk idag hade han nog inte haft samma funktionshinder som han fick för 25 år sedan. Därutav har jag det här och kunskapen på den biten, och tyckte det har varit så viktigt att få jobba och lyfta fram både stroke-drabbade och anhörigas perspektiv under de här åren. Det är väl lite om mig.
Tack. So 25 years ago, her husband had a stroke, and this is today why she's part of the Stroke Association, being the president, that she has own her experience of how care is working in Sweden, and this is also part of why she's there together with the other organizations of Stroke Foundation across Sweden. Bengt-Ivar.
Well, thank you very much, and thank you for the invitation to represent research-based industry. I've been working as a public affairs manager for many years now, and I'm focusing on building collaborations between the patient advocacy groups, between the industry, between all that would like to share vision around creating a better life, a better healthcare, and all of this. So that is my mission within this, and I've been in the pharmaceutical industry for almost 30 years. So something from that experience I would like to share.
Wonderful. Thank you very much. So maybe I will just start with the first question to the panel here. You've been hearing all the presentations. You've had a little chance to reflect on what we heard. So my first question is, how can we make brain health a societal priority? Who wants to take a crack at that? Hur kan vi sätta hjärnhälsa som en av de stora prioriteringarna i Sverige? Bengt-Ivar.
Well, I think it has been mentioned a lot of times. I think the key is collaboration. We have to be collaborating, like Alex mentioned before as well. All of us has to chip in together. The industry has to chip in together with the healthcare sector, with all the physicians and nurses, and all those other stakeholders that actually needs to do good healthcare. So I think collaboration is one, and also one other thing is when having when research-based innovations comes to bay, it has to reach the patients, because an innovation in a pharmaceutical or whatever that doesn't reach the patient is pointless in a way. So we have to reach all the way out to the patients. That is the important thing, I think.
Så samarbete och innovationsupptag är två viktiga faktorer för att sätta det på kartan. Any more, Professor Ring?
Yeah, I can make some comments. That I think we're still looking for the ideal format, how this will come into practice and work well. And if we're looking back, I remember the first steps 15 years ago when it was a start between some organization, and I was part of that we should focus on brain health, and it was from the World Federation of Neurology and the World Stroke Organization and some others. But still we have difficulties to say what would the format be, how should we have an interaction. And then we've seen the birth of several different types of organizations. We have the Swiss Brain Health Plan, for instance, is done from a limited research institute. They have got very aspirational ideas, but it's still on the paper. They have not reached out. They haven't accomplished anything, but these are good ideas.
Yeah.
And then we have, in Norway, we have a national brain health plan since 7 years. And it's run by the government, by the Hälsodirektoratet. It was an evaluation after 7 years, last April, and it was actually thumbs down that they had not reached out, they didn't have accomplished anything, they were too isolated, they didn't have the platforms or so. And we've seen different examples, and I think for me also that what do we want to reach out, the example you have in Portugal, I think this is brilliant. That you need to have the organizations coming together, scientific organizations coming together. You need to have the extension and the platforms out to a governmental level for implementation. And we can also have a strong focus on prevention. For many of the neurological diseases, this is key important, and that is a role which others are not taking upon. But I think we are coming towards good way, and then we have initiatives that mainly has a focus on research, and while research is ongoing we are waiting, but we don't implement so much. We have the Paris Brain Institute, which is doing fantastic research here, but I think you need to be multidimensional and work and just to raise it as much as possible.
Carina, vi har ju sett några, Alex, I'll let you in a second. Vi har ju sett en del initiativ i Sverige. Vad tycker du behövs för att sätta hjärnhälsa på kartan?
Men det är viktigt att vi faktiskt möts och samarbetar tillsammans. Alla vi förbund som då står för hjärnan och så. Och det är ju viktigt, för vi har ju ändå samma mål, tänker jag, det här med viktigt att lyfta fram och komma längre fram, men också att, tänker jag, som nämndes här innan med rehabilitering, att lyfta de sakerna också. Och sen när det gäller forskningen som man då vill ha hjälp, att man också tar med sig de här patienterna, patientorganisationerna som också kan komma med input från hur det är.
Och görs det idag?
Och, både och kan jag väl säga, men det kan ju bli så mycket bättre, tänker jag. För tillsammans så är det faktiskt mycket bättre att kunna lyfta sakerna.
So it's again the partnership in between the different organizations, within the field, also the patient organizations, and getting their also research perspective in. Now, Alex, this has been in place now a year in Portugal. So has this put brain health on the agenda?
Definitely not. So we need to move on, and basically we need to rally for the brain. And one of the proposals that I would forward to my colleagues in our next meeting, we need to rally for work. And our current Prime Minister is in his campaign, let the Luis work.
Mm-hmm.
Luis is his name, Luis Montenegro. So we will say, let people with brain diseases work, please. And we will try to do it as a national campaign and rally over the city centers of all the Portuguese cities. Otherwise, would be invisible. Because most of the brain, the brain symptoms, or for instance, multiple sclerosis symptoms, are invisible. So people they don't see it. They don't see it. They don't value. And one of the things that now the research has proven is that being able to work, being able to gain money to be independent is therapeutic for multiple sclerosis. So we need to work. Let us work. And that's our motto, and that's what would be my proposal for the next meeting, because we need to go to the streets. Otherwise, nobody would care with us.
Så det behövs mer advocacy. Det kan inte ens komma på vad det heter på svenska just nu. Men som du säger, det är viktigt att det här är osynliga sjukdomar. Det är viktigt för självkänslan också att man får en möjlighet att arbeta och komma ut i arbetslivet. Sweden has a risk of overcomplicating things, overstructuring things, and maybe, do we have a problem with over-fragmentation or over-complicating things if we were to do what our friends in Portugal have done, which is to put a broad coalition together for brain health? What's your take? Anyone wants to take a take? Professor? Yeah, go ahead.
Definitively. Yes, we have all these silos, and we have everything that is going on within the different disorders, and this is a new concept really that is so important that it needs to bring forward, but it's difficult to really to find what is the format of this. And then also, of course, we need to recognize that it's not alone. For stroke, for instance, is part of the cardiovascular diseases, is one of the important ones, and it needs to be recognized that it is a brain disease as well. We have the cardiovascular European plan upcoming, and sorry to say, the stroke is almost forgotten there, which I think it needs to be corrected. But it needs to say that, yes,
so it's an internal competition as well in between diseases.
It's a competition, but we are friends and we are not competing. But to also define here, what are we asking for? What do we want to change? One thing is to see the numbers. The numbers are staggering, but it's only the start. That what can we change? What can we do? What can we improve? These are the next steps to just don't have the numbers by themselves. But we have also the rare diseases, which have low numbers, which are very important not to forget in this context.
Om man tittar på nationell koordinering, national coordination, who could be the owner, the driver? Vem kan vara ägare i ett sådant nationellt initiativ? Vilken gruppering, vilken myndighet eller kan ta ett sådant ägarskap? Har du någon fundering där? Or anyone else?
Jag kan tycka alltså det är viktigt att tillsammans nu ta den här och ta möjligheten när man nu tittar på de nationella riktlinjerna här, och där man, som du sa, man har faktiskt glömt stroke i det hela, men där vi har påpekat nu tillsammans här många att man måste ta in det, för det är en stor folksjukdom och det är livslång rehabilitering, och det här för övriga hjärnsjukdom också, men att komma tillbaka till ett bra liv efteråt, för livet ska ju fortsätta att levas när man får möjligheten att leva det ytterligare eller en gång till så att säga. Så därför tycker jag det är viktigt att man också tittar rehabiliteringar, för det vi hör det är ju att man är jättenöjd med det man får från början på sjukhus och så här, men när man kommer hem tycker jag också viktigt, för det är ju där man ska fortsätta, och där behöver man också, tycker jag, ta ett viktigt titt eller se över hur det ser ut, och jag tycker att det är viktigt tillsammans, för det gäller ju många utav hjärnans sjukdomar, inte bara stroke, men den känns viktig.
So it's continuing to put an emphasis on stroke also in the guidelines, but also reinforcing the continuum of care. Most individuals are happy with what they get in hospital, but then once they get out to rehabilitation, the world looks a lot different. I would like to ask also our other speakers if you have a thought on ownership for such a hub initiative that Alex has put up. What organization or group in Sweden do you think could take such a role to combat fragmentation and get something done?
Can I start? Yeah, no, so I think we could start a brain council in Sweden. It exists in many other countries, and I think that would be like a focal point for civil society and all kinds of organizations. But I think, and I think that would be good to do that. But I think another, we have been struggling for years from the Swedish Brain Foundation trying to get a brain health plan into action in Sweden. And it's been super difficult because of all of these decisions are made in compartments. And for example, it goes all the way to the top, so that if you're a minister of something, say planning and built environments and things like that, which is important for brain health, they are very keen on not stepping onto some other ministry's turf. And this is a huge obstacle. And so one course that we tried to take was to influence the Swedish Productivity Commission, because it was seen like there was a big crisis in productivity in Sweden. But they weren't ready to take on the brain capital that we thought they should. So I think the next step is for the government to start a brain commission. We actually have kind of a crisis in brain health and in the brain area in general, and a brain commission is called for, I think.
So the National Board of Health and Welfare has a responsibility
No, the government.
as well. Yes, the government.
Yeah,
but
the
what about
government,
Socialstyrelsen?
No, I think it's the government that needs to start a brain commission, the way they start a productivity commission when they feel that there is a crisis in productivity. And they cannot only talk about like physical infrastructure like railroads, they need to talk about brain capital as infrastructure as well. And in an economy like the Swedish or the Portuguese, it's as important as harbors and roads. I mean, it's obvious, I think, to most people, but the Swedish, if we start a brain council, there needs to be a counterpart in the public sector, and that should be run from the government, I think.
Thank you. Hjärnkommission helt enkelt.
Yep.
Any thoughts from you?
Yeah, I can say something. There is, for example, a government initiative that was, it was started there, and developing a national plan for mental health and suicide prevention, for example, that has taken a very long time to develop. It was done in collaboration between the Public Health Agency and the National Board of Health and Welfare, together with, I think, 25 other different agencies. And I'm not sure that would be a good way of working. It takes a long time, and it's maybe not that flexible, but that's an example, of how it could be done.
Thank you. I have a question for the panel here. Looking, 5-6 years ahead, what does success look like if we're able to put brain health on as a priority on top of the agenda? What does success look like? Anybody wants to take a shot at that? Professor?
Yes, advocacy, that brain health is recognized and how big the topic is. And then also prevention. Again, prevention, that there is so much that can be prevented, and this is so important here. And then, of course, self-evidently, we need better therapies, we need better diagnostics tool, but I think this will be grown within the scientific societies nevertheless, but to look at what is added value of having a brain health plan, really, that we should really try to define that.
Så behöver en plan med fokus på prevention och ambassadörskap. Alex?
I would say that success means that in 5 years time we will have a decision from the European Council creating the brain health mission. That would be success for me.
Bengt-Ivar?
I think success looks like that we are all coming together. It is on the top of the agenda, on the top of the policy agenda. Brain health is there, and that you unlock all the potential from all different stakeholders. Because we from the pharmaceutical industry has a lot to offer as well, and we would like to give what we can to participate in these kind of areas. So I think success for me in 5 years is that this is on the top of the agenda. We are all collaborating, and we are all doing whatever we can to unlock the research and everything that needs to be done in this area.
Vi har mycket arbete framför oss alltså. Carina?
Vi har fått en bättre rehabilitering efter vården på sjukhus och att vi sen får en längre och bättre, och att alla över hela landet, att den ska vara likvärdig över hela landet. Det önskar nog jag, eller tänker att det skulle vara så om 5-6 år.
Equal care, I think, is a very important point, because we know that there are discrepancies today between care in different places. So that's obviously one, and also the strong focus on rehabilitation. Before we go into break, I think there was a question almost from the back, if we can take that as well.
It's not so much of a question, more of a, say, if you don't take the patient perspective, you can't take the lead. We have to take the lead, but also not focus on the government, focus on the region, because the healthcare is giving in the region. And also talking about the right treatment in right time, but also supporting of the right time. So that's more important to discuss, but I think if you only take the patients away, you don't have a success. We need to be in the focus. Because you're talking about us as a burden. I'm talking about I have Parkinson. I want to be cured, not to be mentioned as a burden. And that's, I think, it's more important to mention than just talking about us as a burden. Thank you.
Very good, and I think that's a very nice final statement for this part of our meeting today. I'm sure we could have continued the dialogue a lot more on what we need to do in the next sort of 5-10 years to really make brain health a priority. We're now going to go into a break. For those of you who are here for the first time, you will know that there are coffee places. There's one out here and there's one at the back. We're also at 11 o'clock going to be splitting up in 2 different rooms for the parallel sessions. One is this, the other one is just out the door to the left-hand side for those of you who are going to attend one of the parallel seminars. So with that house cleaning housekeeping comment, I would just like to say thank you very much for the discussion. Thank you for joining us here on stage, and for the questions from the audience. Thank you very much.